afternoon. I'm Dr. Ashutosh Marwah. I'm Senior Consultant in Department of Pediatric Cardiology at Apollo Hospital. Today we will be talking about non-surgical options in treatment of congenital heart disease. Most of us have heard about surgeries for open heart congenital heart disease, which are big open heart surgeries. The child requires opening of the chest, and then the defects are repaired, and it usually requires a long hospital stay, 3 to 4 days, 7 to 10 days hospitalization time. Leaves a big scar on the chest wall, and it takes time to recovery is usually between 1 to 2 months before the children are completely well. But not all cardiac conditions require open heart or surgical procedures. There are few conditions which can be handled in Cathlab. So doing an intervention procedure can take care of certain conditions. And the advantage will be that the hospital stay is just 24 to 48 hours. It does not require any major blood transfusions. The scar is minimal in the groin, just like an angiography scar. And the procedures are equally safe and validated. For over 20 years, we have been doing these procedures. So they are safe, and long-term follow-up data is as good as surgical procedures. So very selected number of conditions which can be handled in Cathlab. I'll enumerate. First is the atrial septal defect. As you all know, atrial septal defect is a big hole in the upper chambers of the heart. And we have to selective patients where the defect is well centered, has good tissue rims all around. We can do a closure in the Cathlab using a atrial septal occluder. And these occluders have again been available for 20 years. A hospital stay is usually 24 hours post-procedure, and patients do not need to take any long-term medications. We give aspirin for 6 months, and that is all. And patients can lead normal life. Just after 48 to 72 hours, they are mobile and continue to do daily activities. Then the second lesion, which I want to talk about, is the patent ductus arteriosus. Patent ductus arteriosus is a connection between the blood vessel of the lungs, that is the pulmonary artery, and the blood vessel of the body, that is the aorta. So this patent ductus arteriosus carries lots of blood into the lungs. So from the systemic, from the body. So the children become breathless. They do not gain weight. They suffer from recurrent chest infections. So nowadays, most patent ductus arteriosus, except for very early newborns, are taken care of in Cathlab. So any child who's above 6 kilos weight can undergo this procedure. We have Pda Duct Occluder, and these duct occluders have again been in market available for almost more than 20 years. It's a one-time procedure. Once the duct occluder is positioned, the shunt from the patent ductus arteriosus stops almost immediately, and children are usually discharged within 24 hours. There is no need for long-term medication. Yes, follow-up is needed. We call them after 6 months and 1 year for the echocardiography. Then the third procedure, which I would like to elaborate upon, is the balloon dilatation of valves and narrowed blood vessels. So two valves which are commonly narrowed in children are aortic valve and the pulmonary valve. Aortic valve is a valve which carries the blood into the system, that is towards the body. And pulmonary valve is the valve which allows the blood to go into the lungs. So narrowing on any of these two sides causes obstruction, and children feel fatigue. So these valves can be, taken care of in Cathlab. We have to position a balloon across the valve and inflate it once. And most of the time, these procedures are corrective and do not require prolonged hospital stay. Hospital stay is usually 24 hours. And children can lead normal life. They need to be followed up once a year with the echocardiography. No long-term medications are required again. Then narrowed blood vessels, commonly we see is the coarctation of aorta, which means that the blood vessel which carries the blood from the heart to the entire circulation, to entire body, is narrowed at a point inside the chest somewhere, and obstruction causes stress to the heart. The heart is not able to pump properly, so the blood circulation to the lower body is suffering. So these children often present to us in neonatal period with poor heart function, and sometimes in the older age group with easy fatigue, hypertension. So except for first 3 months of life, where we send the children to surgery, later on in life, balloon dilatation of the narrowed blood vessel takes care of everything. There is no need for prolonged hospitalization. Re-narrowing rates are very few, probably similar to the surgery. And even if the blood vessel narrows again, it can be ballooned open. So there is not like, it keeps on happening again and again. But if it does, then it can maybe 10% chances are there if we do the balloon dilatation within first year of life. And then usually beyond 1 year, the re-narrowing does not happen. So it is procedure of choice in almost all children who are more than 1 year of age. And between 6 months to 1 year, one could opt for balloon dilatation or surgery. Then now we have what we call as stents for these blood vessels. And these stents are expandable stents. Like, it's not like you have placed a metallic stent in the blood vessel, it will not grow with, the child is overgrown the stent. So these stents can be dilated in future to match the growth of the child. So nowadays we are putting stents in at the site of narrowing of blood vessels, say coarctation of aorta, or sometimes in the pulmonary arteries, where the blood vessel in the lungs may be narrowed as a result of scarring because of surgical procedure, or sometimes by birth. So stents can be positioned, and these stents are dilatable stents which can be expanded with the growth of the child. And the biggest advantage is that they provide a solid metal framework, so the re-narrowing of the structures does not happen again and again. Similarly, we have other things such as coils and vascular plugs, which can be used for closing off any anomalous blood vessels or vascular channels. So all these procedures that I have elaborated are well-established procedures. They have been, patient data is available for more than decades, and they have given us good results. Long-term follow-up has been very good and excellent. Thank you. So if there are any questions, I'll be happy to take those. The first question that has come is, what is the best test for congenital heart disease? The best test for congenital heart disease as of today remains echocardiography, which is to be done by a person who's trained in evaluation of congenital heart diseases. Open heart surgery versus Cathlab procedures, the costs are pretty much similar. So the cost for balloon dilatation is somewhere around between 1.75 to 2 lakhs, whereas the cost for device closure procedure is around 2.5 to 3 lakhs, depending on which site are we closing. Say if you're closing an atrial septal defect, then the cost is higher, but for a PDA, probably the cost is much lesser. It depends on the cost of the device more than the procedure charges. There are various types of surgeries, and they have to be catered to the type of defect. For simple defects, it could be just closing the hole, sometimes removing the extra muscle growth, sometimes enlarging the valves. So various combinations which are there. So it could be, it would require an on pump, which means the heart has to be stopped, but some surgeries may be performed without stopping the heart. Common congenital heart defects in adults is bicuspid aortic valve and its complication, where the aortic root dilates and the valve becomes leaky, and which may require a replacement. Patients who in nature, there is about 1% incidence of all the congenital heart defects. So besides that, elderly mothers, then patients who have had previous babies with heart defects or first degree family relatives, patients, mothers who suffer from diabetes or are on any type of medication such as phenytoin or warfarin, or if they suffer from rubella infection during pregnancy. So yes, the families can be at risk of having a baby with heart defect. Life expectancy for congenital heart defects is probably, again, varies with the type of defect. For a simpler defect such as atrial septal defect or a patent ductus arteriosus or a simple ventricular septal defect, what we call is a hole in the heart, the life expectancy is similar to the control or the normal population. Whereas when you're dealing with single ventricle physiology, where part of the heart is underdeveloped, then yes, the life expectancy is lesser than the control or the normal population, but it's not very low. So most people then again live to around third or fourth decade. Congenital heart disease, curable, I would not say curable, I would say amenable to correction and gives long-term good normal lifespan. Treatable conditions. Signs and symptoms of congenital heart defect can be varied. Many children present with poor feeding, poor weight gain, fast breathing, they sweat when they feed, and they keep on having recurrent chest infections. So that is one group. Then the other group may have blueness of nails and lips. So that is the second group. And then third group, which may have minor or moderate defects, they just present as with murmurs or easy fatigue. So there are various types of defects. So earlier the presentation is more severe defects. So if the child is presenting within first 3-4 months of life, we know that it's a severe defect. If the condition has been treated or untreated, for most conditions, we ask the patients to be under follow-up at least once a year. It is best for the cardiologist to decide that how frequent follow-up is needed. But I would say minimum is 6 months and then once a year. Usually, there are no dietary restrictions for congenital heart defects except when the patients are taking blood thinners if they have had a valve replacement. And activity again is symptom limited. If a patient gets tired and has, so they must inform their cardiologist, and then the advice can be given accordingly. Yes. No more questions now. Thank you. Thank you very much. ये मैं कहाँ देख सकता हूँ?